Good afternoon, ladies and gentlemen. I'm Dr. Li Chenyu from Linkou Chang'an Memorial Hospital in Taiwan. It is truly a privilege to be here today and share our work. In cervical traumatic SCI, one of the most challenging decisions is whether to perform Duraplasty. We decompress the spine, but we knew few about the perfusion. Today, I will present a preliminary analysis from the ongoing ISCUT randomized control trial. Explore whether intraoperative ICG can identify perfusion phenotypes and then guide a decision-making. So as we all knew, secondary injury is perfusion-driven. Microvascular failure and loss of reserve determines recovery. Yet surgical decisions are still largely based on morphology rather than physiology. So our goal is to determine whether first-pass ICG metrics could fill this gap. So ICG, all neurosurgeons are very familiar with that, but they have some special characteristics. So to avoid circulation, the method we use is called first-pass ICG metrics. We analyze this metrics into 3 domains: inflow, time to peak; washout, time to first pass end; and perfusion reserve, represented by first pass AUC. And to enable cross-patient comparison, all these metrics were calculated at lesion minus caudal reference, while intensity was analyzed as ratio. We believe that this method can capture inflow delay, clearance capacity, and structural reserve in a single injection. So this is the analysis platform we designed by ourselves. The ICG recording was done after laminectomy. ROIs were placed at the epicenter and the caudal segment in fixed pixels. Curves were derived from discrete smooth data, and first pass ends was uniformly defined for standardized perfusion quantification. And to validate ICG biologic relevance, we tested its correlation with 3 domains: preoperative injury severity, MRI-based lesion length and expansion rate, and 3 months neurological outcomes. So 17 patients from the ISCUT trial, and this is ongoing trial, were included. This is an exploratory interim cohort analysis, so the trial remains ongoing. So first, the correlation with the injury severity. We found that greater washout restriction correlate with worse preoperative ASIA grade. Reduced AUC ratio, first pass ratio correlate with longer intramedullary lesion length. Delayed inflow correlates with 2-week MRI-MLL expansion. We believe that these findings suggest that functional severity is associated with lower microvascular clearance, while structural damage reflects reduced perfusion reserve, and delayed expansion is associated with inflow delay. How about 3 months? We found that higher AUC first pass ratio was correlated with ASIA conversion rate and walking ability improvements. Preserved washout duration correlates with greater motor improvements. These suggest that perfusion reserve predicts neurological and walking recovery, while microvascular clearance reflects motor recovery potential. Therefore, based on these findings, we propose a 2-axis phenotype model. The axis A represents structural perfusion reserve, which measured by AUC first pass ratio. Axis B represents microvascular clearance, measured by delta washout duration. Delta TTP serves as a supplementary inflow modifier. So based on this framework, patients can be stratified into 4 perfusion phenotypes. The left upper one, type 1 represents microvascular dysfunction, which means preserved reserve but restricted washout. Type 2 shows preserved perfusion in both dimensions, and where we believe that Duraplasty for these patients may be deferred. Type 3 demonstrates combined impairment, suggesting a higher likelihood of benefits from expansion. Type 4 is the most interesting one. It reflects reduced reserve but preserved clearance. So in these cases, we believe is because of the structure ceiling effect. So you might need to look at inflow dynamics, such as delta TTP. If inflow is delayed, then they might need a Duraplasty as well. So of course, there are several limitations should be acknowledged. The first one is this is still a small interim cohort, and the analysis is exploratory and without multivariable adjustment. Correlated findings do not imply causations, and this proposed framework is hypothesis generating. But in summary, in our study, we found that AUC reflects structural perfusion reserve, and washout reflects microvascular viability. We present the first ICG-based physiological framework for Duraplasty, a decision support in traumatic cervical SCI. Longer follow-up and further validation are required. Finally, I would like to acknowledge our software engineering collaborations, the a company who developed the real-time analysis platform together with us. And also our team member over there, the ISCA trial team, led by Professor Lu Yuren and Dr. Li Yingqing for making this work possible. Thank you very much.
My name's Alan Levy. I work at the University of Miami. I want to congratulate Dr. Li and his colleagues for an excellent piece of work and very timely. Big picture, in the management of acute spinal cord injury, we have a number of tools in our tool shed: early surgery, mean arterial pressure greater than 85, in our center and some other centers, cooling, CSF drainage, decompression of the spinal cord, and then this concept, and a relatively recent concept, of supramaximal decompression of the spinal cord via Duraplasty. And again, why it's so timely is that there's now a DoD-funded study in the United States, and we are one of the sites, and Dr. Rajiv Saigal is the PI for overall sites, to try to look at this and see whether it's helpful in a prospective fashion. And so this work is so important because it will hopefully give guidance for future work to see whether it really should be done or not. And I think what you did show us is that you can potentially increase blood flow by doing a Duraplasty. That's an important piece of information. It's not clear, of course, whether it does increase neurological outcomes based on this study. The only thing I would say is that you always have to look at what cost. Obviously, doing a Duraplasty increases operative times, potentially increases CSF leak rate, and in many times, because you're doing a wide laminectomy and it has to go over multiple levels, it will increase the amount of fusion and decrease the mobility in a patient who already has immobility. But overall, excellent study and congratulations.
Thank you so much.